Dr. Sadat and Dr. Buck. And then Dr. Buck, I'll have you introduce the two trainees who made time to be here today. I'm super excited about that. I think that's really going to enrich the conversation. So we are really, really lucky to have Dr. Mohsin Sadat with us today. He has a PhD degree in medicine and public health from the University of Melbourne in Australia, Master of Science in Infectious Diseases from the University of London, the London School of Hygiene and Tropical Medicine in the UK. And his MD degree is in Mozambique from the Eduardo Mondlane University, where he currently works. He's a faculty member and researcher at the Department of Community Health and the Faculty of Medicine at this university. And he was also the Dean of UEM from 2012 to 2019. His teaching and research interests include infectious diseases, implementation research in health systems and public health, and research and medical education. I also want to take the opportunity to introduce Dr. Buck. For those who have an interest in working in Mozambique, whether it be in the pathway or the concentration, he's going to be your point person and a great person to touch base with. We'll also be in Los Angeles next week, so it's a great opportunity for you to be able to meet with him in person. He's an associate professor of pediatrics at UCLA, but he also lives year-round in Mozambique. He's the lead for our programs in Mozambique, KwaZulu-Natal, South Africa, and Brazil. He supports in Mozambique pediatric surgery and family medicine residency training programs throughout the country. And he also serves as the focal point for all UCLA medical students and residents who complete clinical and research rotations at the Hospital Central de Maputo. And he provides clinical care there on the breastfeeding ward with the infants. In addition to Dr. Buck's medical education and clinical work, he leads a research team that has several ongoing studies and clinical trials and leads a PEPFAR funded project providing technical assistance to the Mozambique Ministry of Health, pediatric HIV and TB programs. And prior to joining UCLA, he worked for the Baylor International Pediatrics AIDS Initiative in Malawi and for CDC in Mozambique. So I will turn it over to Dr. Buck and Dr. Sadat and to our wonderful trainees, Beauty and Hajra, for the conversation. Thank you so much.
Thank you very much, Tracy, for those introductions and for our opportunity to interact with you guys today. I really enjoy these chances to speak with the UCLA medical students, get to know you guys, but also to introduce you to some of the wonderful people that I work with here in Mozambique. So our goal for today is we want to share a little bit with you what is the medical education experience in Mozambique, and maybe, we hope this is much more of a discussion and less of a presentation. But I think it would be very interesting for you guys to compare and contrast what you're going through compared to what the experience is here for students and for residents. So Tracy introduced Dr. Sadat, who is a good friend of our partnership. I see Dr. Miller joined. Lee and Mohsin have a long friendship together and professional collaboration. So welcome, Dr. Miller. But just briefly to introduce Beauty and Ajra, I didn't get as detailed of information as I should have on them. So you guys feel free when you speak to give more information. But actually, you know what will be better? I'll let you guys introduce yourselves. So maybe we'll start with Beauty. Just tell everybody a little bit about yourself and where you are in your training, okay?
Okay. So good afternoon to everyone. I'm Beauty Petey. I'm 24 years old, currently attending my final year as a medical student at Eduardo Mondlane University. And it's a great honor to be here with you guys.
Thanks, Beauty. And I can tell you guys a little about Ajra. She's a pediatrics resident, and she actually has collaborated with UCLA medical students. Prior to the Discovery curriculum, we had a program called the GSTTP, which was the Global Short-Term Training Program for students in the summer between their first and second years to come and do global health-related research. And Ajra worked with a couple of UCLA medical students on an interesting project from our pediatric emergency room that we published. But Ajra, I'll let you tell the group a little bit about yourself.
Hello, my name is Hajra. I'm a fourth year resident in pediatric. I also studied in Eduardo Mondlane University, and after that, I worked 2 years in the emergency department in pediatric, and that's where I found my passion in children and decided to do my residency in pediatric.
Thank you, Ajra. So I think our goal for today is I'm going to help moderate discussion, ask Beauty some questions for her to share with you guys a little bit what is the medical school experience here. And then we'll do the same thing with Ajra. And I hope to wrap that up by the mid-hour. And then I want to turn it over to Dr. Sadat. And he's prepared a few slides, and I really want him to help contextualize what Beauty and Ajra share with us in terms of like the perspective of a medical educator and perspective in the context of the health challenges and the health financing challenges that Mozambique faces. You know, what are the challenges and what are the opportunities in medical education, and how are we trying to respond to them? So as we go along, please feel free to interject, raise your hand if you have a question. Mohsen, feel free to interject if you need to. But with that, I think we can get started. So Beauty, you referred to the fact you're in your last year of medical school. Can you tell folks a little bit? In the US, people go to university after high school for 4 years, and then they apply to medical school. And it's a bit different here. So can you explain how that works and how you got into medical school?
Oh, yes. So first, it's very important to to mention that here in Mozambique, we have public universities and we have also private universities. But overall, the criteria to be admitted to medical schools are quite the same. We normally month like November, December, and then January, some universities, they publish documents where they give the names of the courses, the type of exams that we need to go through to get admitted in those universities. So criteria number one to be admitted is to be someone who has finished the high school. You call it high school. Here we call it secondary school. We say 12ª, that is the last year of high school. So that's criteria number one. Then we have criteria number two, that is to apply to the entrance exam. Here we have biology exam and then we have chemistry exam. Both of them have around 60 multi-choice questions where we have to choose each one, and then wait for the results on the next weeks. And the final criteria to be admitted to a medical school is to have the average grade of that university. For example, if you want to get admitted to Eduardo Mondlane University, you are going to do the exam, and then we have a score from 0 to 20. And for example, Eduardo Mondlane sets 18 as the average grade. And then they're going to select all the students that had 18 and above that grade. So that's basically how we get into medical schools.
Did your grades in high school matter at all, or was it only your performance on those exams?
Not really, just the entrance exam that counts.
Okay, so we know you passed that step because here you are finishing your med school. So maybe describe to everybody what is in the US, medical school is 4 years, and there's variation. Usually like the first 1 or 2 years are preclinical, and then there's a shift towards clinical. Can you explain to everybody a little bit how the medical school curriculum is structured in Mozambique?
Yeah, so here in Mozambique, we have universities that to get a medical degree, you have to start for 6 years, and then you have other universities that you have to start for 7 years. For the university that we go through 6 years, we have 3 phases. The first phase is for the first and the second year, that is preclinical years. Then we have the second phase where we have the third, the year 3, year 4, and year 5. And then we have the last phase that is the integrated internship, that we have the professional part of the medical degree. So the first 2 years, years 1 and 2, it's basically theoretical years. We only have lessons and subjects. We have approximately 19 subjects that are divided into 4 semesters. And then we just stay at school, just the theoretical part. And that's basically it. We focus on definitions, epidemiology, etiology, and the theoretical part. So after that, we have the clinical part, where it's year 3, year 4, and year 5. Then we start going to the hospital and centers, and we start having this contact with patients. So it's when it all starts. This is the most overwhelming part of our course, because it's the first time we have this connection with patients. And it's also, I think, the most difficult part of the course, because we need to be very responsible for what we do. I feel like here in Mozambique, we are very lucky in our clinical phase, because from the very first day, we have the opportunity to be able to touch the patient, to be able to do exams in our patients, to be there with the patient. Because sometimes I feel like in other countries, they're not allowed to do these kind of activities from the very first day. And we do really have this opportunity. So it's something that is very, very, very great for us. But we also face a lot of difficulties, because we have lack of material resources, even for the doctors, even for the students. So it's something that it's not good for our practice and our medical experience. Overall, I feel like sometimes we also lack a little bit of guidance from our mentors, because we have a lot of students. We have so many universities, and these students go to the same hospital. For example, the Maputo Central Hospital is the biggest hospital that we have here in Mozambique. So we have so many students, and we have 2 liters of mentors. So that sometimes makes it difficult for us to have the right guidance, and to know what we are doing, and how we need to do things.
Thanks, Beauty. You mentioned the last year, the year, what we call like our intern year. For the medical students there, it's very similar to what like a prelim year would be if you were going into surgery or radiology, where you rotate through internal medicine and pediatrics and gynecology, and you do a community rotation. And so after you finish your intern year, and this will kind of wrap up your part, but tell folks a little bit about this exam you need to do at the end of medical school, and a little bit about what you and your classmates are thinking about in terms of work. You know, in the past, the Ministry of Health was able to guarantee that all graduating doctors would have employment in the National Health Service, and that's no longer the case. So please share with us a little bit about where you and your classmates are and thinking about your future.
Okay, that's true. You pointed something that is true, that as opportunity right now, most of us, when we are graduating, when we are at our final year, the first thing that we think it's we need to get a job, right? And I'm not going to lie, here we do have many areas that we can work with a medical degree. I'm talking about the healthcare system, hospital centers. We can also work at education as medical teachers. We can also work at the justice system as forensic doctors, and so many other areas that we have the opportunity to work. So we don't like areas to work. It's not only just the health system that we can work, but then we have the challenges. There are so many. The first challenge that we have is the lack of employment here in Mozambique. So the government used to place us in centers, in hospitals after we finish our degree. But now we have to wait contests so that we can apply and then wait for the result and then being placed in a hospital, in a center. And sometimes this contest can we need to wait for 6 or 8 months, and we're just staying at home, forgetting what we have learned, and it's very difficult for us. And that leads us to the second challenge that I think that we all feel here, that is the lack of acceptance in private and in private jobs. Well, when we start seeing that we are not getting into the national system of healthcare, we start thinking about going to the private sector, right? And the private sector is also full because people are all running to the private sector. And also the private sector is very strict, very, 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 very strict. And we do have problems into getting to them. So that's a big problem. And then we start maybe thinking about going to other countries, but then we face other problems because in other countries, they don't accept us Mozambican to perform medicine there. We need to do a correspondence to be able to perform medicine there. And sometimes it's just so difficult to get that, and people just give up and just come back here. And then we have the last one that I think that's very prominent, is like the lack of scientific research. I feel like we don't have that mind of wanting to be involved in the scientific research area. And then we realize that too late when we are just finishing, and maybe we want to apply to a job overseas, or we want to do a master overseas, and they ask, okay, what guidelines or what research have you been doing? So it's hard for us because we were never taught that this is something very important for us to be able to go overseas. So I feel like we are lacking a lot of scientific research. So that's basically the challenges that we have now in our country as medical doctor or soon to be graduating students.
Thank you, Beauty. It's so interesting to hear from you. And Dr. Sadat is going to share some slides at the end that talk about Mozambique's physician density and our relative lack of human resources for health. And this fact that we have medical doctors who are sitting idle at home and aren't employed is something that really is frustrating. So we're going to turn to Dr. Ajra now. And for the students at UCLA, I'll just clarify that in the US, most people go into residency training immediately after you graduate from medical school, but it's a little bit different here. So Ajra, I'll ask you to start by telling folks a little bit about what you did after you graduated from medical school. And in general, what are the requirements for somebody to be eligible to apply for residency?
So thank you for the opportunity for me to share my residence experience. When I finished med school, it was a bit different. It was 8 years ago. So after I finished med school, I didn't have to do the other board exam to be in the Ordem dos Médicos. I didn't have to do an exam after I finished med school. I immediately got attributed in the hospital. I immediately had a position to work because they were lacking doctors. So I started work immediately after I finished med school. And it was, in a way, I think I was very lucky because I didn't face any challenges after I finished. I got work, and after I worked for 2 years, I applied for the exam. I had to do another exam to be part of the residency. It's just a 4-hour exam, writing exam. in pediatrics. And after you finish, you have 1 year that you can decide when you want to start, and then you start the residency. I think I
So
was
yeah,
very
one thing to clarify, different here is that residents might start at different times during the year, unlike in the US when everybody starts at the exact same time in June or July. So, Ajra, some people, do they know? I think some people applied for residencies in several different areas, right? Because they're not sure if they'll get accepted into their first choice. Can you speak a little bit about that?
So when you're applying for residency, you have to see if there's any availability in that area. Sometimes they say we only accept 10 people or 2 people, depends on the residency you're gonna choose. So you have to put two or three options. And depending on your grade, if you have a higher grade or lower grade, then they're gonna attribute you to a specialty. Some people choose pediatrics and they have a lower grade and they go to another area, and after that they have to repeat the exam 1 year later, and then they can go to where they want. So it's a challenge also.
Thanks. And now tell us a little bit about your residency experience in pediatrics. Where are you? How many years do you anticipate it's going to take you to finish? And what do you have to do to finish residency and be considered a pediatrician?
So in our residency, it's a 4 year residency with 2 exams. One exam you have to do after you finish 2 years, and it's divided in a theoric exam where you do a writing exam for 4 hours, and then you have to do a practical exam where you do a clinical history in a patient, and you have to discuss with members of the jury, and they ask questions about your patient and your clinical history. So you have to pass both exams to be able to go to the 3rd year. And the last exam is when you finish the 4th year. It's your last exam. It's basically a writing exam, and then you discuss also questions about general pediatrics with the members of the jury also. I already did my first exam, so now I'm on my last year of residency. And it's actually not, I've actually been doing my residency this is my 5th year, but I had two babies, 2 children, so I had to stop and then continue. So it's also a challenge to balance your own life and your goals also. So
I was always impressed when I saw you like working nights and evenings when you were like 8+ months pregnant. You've been amazing. You know, you talked about 4 years. Sometimes it ends up being longer than that, not because of breaks for pregnancy leave, but because the rotations that residents need to do aren't available. And that's something that's always frustrated me, and it's quite different from what happens in the US. Can you explain that?
Yeah, usually when you go in the residency, you have to finish certain rotations. So there's a group of residents that go in the first year. They put all of them in for example, in neonatology. So all of them start neonatology and then go to the other rotations. So after they finish neonatology and go to the other rotations, neonatology has no more residents. So the other people that are already going forward in their residency have to stop and then go and cover the loss of residents in neonatology. I think there's a lack in programming. Like when you go in, there has to be like a future plan. This is when you're gonna do this rotation, the next rotation, like just a future plan of your at least 1 year or 2 years of residency. And we are definitely lacking in that. This lack of organization, I can say. So it's a
Thanks,
bit
Ajra.
frustrating. Yeah, it's a bit frustrating that you have to repeat rotations without actually being bad. You're doing good in your rotations, but suddenly you have to stop. And it's also brings a lot of motivation to move forward and continue.
Yeah, thank you. I would definitely be frustrated if I had to go through that. Unlike medical students, folks who are in residency generally will have the opportunity to work in the national health system when they finish as specialists, right? But you know, in the US, finishing residency is a time where you're finally free and you get to choose exactly it is what you want to do and where you want to do it. But it's a vulnerable time point for a lot of folks when they finish residency, because the choice about where they go to work isn't necessarily theirs. Could you talk a little bit about that?
Yes. The choice where we're gonna work, it's the same as when you finish med school. They have to attribute you a place where you go and work. And sometimes that is a challenge because you have to move away from your family. It's there's no right or wrong place to go. You just have to go where they need a pediatrician, for example. So that's definitely a challenge. But they do give like mothers and women, they do give us a choice where we want to stay. But unfortunately, we are just women working here, so there some women have to leave their family, and it's a challenge. But it also is an opportunity for us to be independent and to um, just um, uh, learn how to administer a hospital and take care of other patients without having just being on our own. So it's a nice experience also that I would like to have.
Thanks, Azra. Just so to contextualize for everybody, Maputo, which is the capital, is in the southern part of Mozambique, and the vast majority of our specialist doctors, anybody who's completed residency, are based here. But the ministry is trying to improve the distribution of specialists throughout the country, as they're doing the same thing with general medical doctors. So thank you very much, and I think we're right at the half hour. So Mohsen, I think this has been a really good introduction for your part. So we'll turn it over to you. Tracy, is screen sharing available? Will he be able to share his slides?
I think he can just, yeah, click on the share and it should work. Perfect.
So I will start by saying hi, everyone. It's a pleasure and honor to be here and have this talk. I would like to thank Chris for inviting me. And initially, I was not very sure exactly what to talk, but then interaction with Chris, it helped me to focus my talk. It was great to hear what Beauty and Hajra said. It's very important. Perhaps I will add during my talk some of the aspects related to what they said. So before I speak about Mozambican medical education, let me say that Mozambican population is essentially very young, as you can see from this slide. Lots of health issues and other socioeconomical issues plagued our population, and because of that, the life expectancy wasn't very great, but it's improving now as socioeconomical conditions are improving, as well as health services are improving. I won't go in detail in each slide, but hope I will share my slides. If you need more details, you are welcome. Currently, there are about 33.6 million inhabitants in Mozambique. And the population is growing because of our fertility rate, which is still very high. It's among the highest in the world. And it is estimated that we'll have a population growth of about 3% per year up to 2050. our epidemiological profile of diseases is quite different from developing countries. We often say that we have a double burden of diseases, where we see chronic non-transmissible diseases gaining importance in our setting, but also we continue to see important impact of infectious diseases. So although as the country is growing or developing economically, and social structure is improving, etc., we still see considerable burden of infectious diseases among us. However, we start also, because of our population is also growing, aging, and because of also changes in lifestyles, global influence and fast foods, etc. Lifestyle that we have is very similar to lifestyle of developed country, particularly in urban areas. We start having more cases of non-transmissible chronic diseases. This is why you can see, for example, this that I obtained from health metrics. You see that, for example, in 2011, HIV was the #1 cause of death, but it still continues, because Mozambique is one of the 10 countries with the highest burden of HIV infection. And this graphic is a bit confusing because of COVID, which is, as you know, it's kind of a noise that is making, because it's not something we'll see over decades. It's something happened. But you see, malaria is still an important cause of death. You see neonatal disorders, very important. This is related to a weakness of our health system. Then you see like tuberculosis, lower respiratory infection, and diarrhea. They are still very important causes of death. Strangely or not, although we see already burden of chronic diseases growing, we continue to see infectious diseases still having considerable burden, but we are also having an increase in the burden of trauma and violence, particularly road injuries, which is also becoming a very important issue. So many times we say that Mozambique is facing triple burden of diseases. So we have chronic diseases, we have infectious diseases, and we also are facing considerable burden of road injuries and trauma due to other causes. What are the risk factors? Most commonly mentioned, these are almost same, not much change between different periods that you can see here, but malnutrition is one of the important risk factors. Mozambique has a strange phenomenon where we have malnutrition still common among us in different parts of our country, but we are also having problems with obesity, overweight and obesity as well, due to changes in lifestyle, and therefore we also see some chronic diseases related to it. But still we have problems with the unsafe sex, air pollution, problems with water hygiene and sanitation. Still around 30% of population have limited access to proper drinkable water. Sanitation is still problematic. That's why we often have epidemics or outbreaks of diarrheal diseases, including cholera, etc. Other factors are there, I think you have seen. However, since independence, since our independence was in 1975, in 1976, the whole health system was nationalized, meaning private practice was prohibited, and the government was responsible for providing free of charge health services for all Mozambicans. This was helpful to provide access to healthcare to all, although our health network is limited, and I'll show you some slides related to that. During the independence, our health coverage was around less than 30%. Now it is estimated around 60%. Due to extension of health network, increase in number of health professionals, etc., you can see changes that we capture in what we call demographic health surveys that are done periodically. Demographic health surveys are done because our health information system is not very good. So for us to have a proper picture of what's happening in our country, this is one of the best ways that we can see what's going on in terms of health and demographics in our country. So you can see clearly that maternal mortality, infant mortality, I mean, this is only, maternal mortality is here. I don't know if you can see the slide, 14.3 graph. You can see decrease in maternal mortality, but you can see also decrease in different groups of neonatal, infantile, and juvenile groups. Considerable reduction. So repeating, this is due to extension of health network, availability of health professionals, qualified health professionals who can take care of children and women. Perhaps it would be important to mention that since independence, Mozambique adopted priority for primary health care, and within that priority, children and mothers were top priority. So the whole health system was structured to prioritize this two groups, mothers and children. And perhaps that's why you see sometimes complaints that men are left out, and now there a huge movement to try to also cater or provide services for them. So this graph I present just to show you the distribution of health facilities. This is Mozambican map. Let me see if I can get the laser pen. You see the number of health facilities in Maputo city, which is capital, and Maputo province. They are high in number, and as you go high, they reduce. Nampula province, which is here, and Zambezi province here, they are most populated provinces. But if you see the number of health facilities compared to particularly high-level health facilities, because you can see here in these tables the differentiation of health facilities. In Mozambique, we have different types of health facilities, from central hospitals to different type of health centers, where you have maternity or not sometimes, depending on type of health facility, and you can see huge differences around the country. And also in private health facilities, as you can see, and Beauty mentioned that there are not many opportunities for doctors to be employed in private sector. In Maputo, private sector is quite developed. You can see here, for example, this assessment was done in 2019. We had around 141 health facilities in Maputo, but only 12 in Maputo province, and you see in some provinces like Niassa, we only had one. So this also to show that Mozambique is, although we often present aggregated data about Mozambique, but there are considerable differences between provinces, and some provinces have worse indicators. Namely, Nampula and Zambezi are provinces with poor indicators, not only because of highly populated provinces, but also because of poverty levels, which is quite high in these provinces.
Mohsen, sorry to interject. I just wanted to let you know, I do want to save time for discussion. And we have a hard stop at the hour, so I have about 10 minutes for your part, okay?
Okay, I'll be quick. This graph is just quickly to show that the coverage is increasing. In 1990, we estimated 24% of coverage in terms of access to healthcare. Now is estimated about 44%. But there is data also that says it's around 60%, depending on what source you look at. I'll skip this. This is related to sources of payment. This graph is just to show that the burden of diseases in African continent is quite high, but the number of health forces, this graph is a little bit old, but still the situation has not changed much. You see the number of health workforce is still scarce, is very low compared to the need. And you can see also the number of medical schools to prepare, they were very low, although now we see some increase in the numbers. I'll skip these two slides because they are related to health workers. Mozambique still faces scarcity of health workers, including doctors, nurses, and other health workers. And you can see here in this table that the number of doctors that we have per 100,000 inhabitants are still, it's growing, but they are still very far from the ratios that are recommended by WHO, which is 1 doctor per 10,000. So still very far. Again, to show the diversity, provinces with better ratio of health workforce and other provinces with worse. The red one are worse, and the yellow and the green ones are much better. So I will quickly say that there needs to be interaction between the education system, particularly education system that prepares health workers, and the health system. And until 1992, this dialogue between the Ministry of Health and the training institutions of health professionals was very good. Actually, Mozambique was a country with a centralized planning system, meaning so they had plans for the country for every decade, how many doctors they needed and how they are going to train within the country and outside the country, which was lost after 1992. We don't have much time, but so I'll pass. I developed this graph just to show some historical periods. The first medical school was established in 1962. So it's the one that I work for, UEM. It's the only medical school that have infrastructure properly built to be medical school. All the medical schools that came afterwards, they were not the building, the infrastructure, the labs, etc. They were not developed for a medical school. Anyway, so the first cohort of medical students were taken in 63, and up to 68, the students had to complete their academic years here in Maputo, Lourenço Marques that time, and then the degree was obtained in Portugal after completing internship. This changed in 68. From 68 to 76, the whole training was done in Mozambique. In 1960, we had independence in 1975. 1976, the name of our university changed from the name it had before independence to Eduardo Mondlane University, which is still now. From 76 to 94, we had only public health system, meaning there was no private practice allowed. So the whole system was under the public, under the government management. And up to 2000, we only had one medical school in the country, which was the UEM. After 2000, we start having new medical schools. The first group of teaching staff, Mozambican local teaching staff, that was admitted to be full-time lecturers was between 92 and 94. Before that, we had some Mozambicans participating in the teaching on part-time basis, particularly clinicians that were at Maputo Central Hospital. And we also had many teachers that were from other countries like East Germany, Cuba, Soviet Union, Sweden, Holland, Denmark, Norway, etc. So between 76 and 92, the curriculum that was implemented was discussed in 77 in a national health council, where they define what type of doctors they need for Mozambique. And we still use that as a reference to guide our curriculum. And that time they developed a curriculum for 6 years, as it is now. But between mid-1990s and 94, they changed to 7-year course. In 94 to 2000, they had again a revision in medical training. So let me say that a part of clinical subject or basic science subject, the curriculum after independence was enriched or was complemented with many public health related subjects like health management, epidemiology, biostatistics, and other subjects related to public health, including main national programs in the country. This is because the doctors, as was mentioned by Hajra, that after completing their course, they were immediately admitted, and many doctors had to work 2 years compulsory in a National Health Service, and many of them had, a part of clinical duties, they also had managerial duties, so they needed to be equipped with some competencies. In 2004, we had, again, a revision of our curriculum, which was changed from 7 to 6 years. This was done by a group of Cuban consultants. We had a hiccup between 2008 and 2012 when there was attempt to introduce a problem-based learning, trying to transform the training more student-centered, and this didn't work well, so we came back to the previous curriculum. Okay, I'll skip. So currently, we have many medical schools. I have mapped here, private and public. We have 4 public and 3 private, but there are 2 almost starting. I'll skip these slides, and I think Beauty spoke a bit about this. But let me say that the 6th year is kind of, because the training actually finishes in the 5th year. The 6th year is something that in many countries is done outside the university. In some countries, it's done within the university. We call it professionalization year, and students in this year, they actually are awarded, students under comma, they are awarded percentage of salary of general practitioner, like 80% of the salary. Because of that, because they actually by doing internship, they actually also work in the hospital. So I'll also skip this if you have questions. Let me just go back and say in 94, the country allowed again introduction of private practice. And also, this is where the private universities start coming up. So this is also an important factor to keep in mind. Okay. So, okay, let me talk about retention retention is also a big problem. Salaries in the public sector are not very competitive. And a colleague of ours did a study, which is now a bit old. The reference is here. And they interviewed some doctors, and many doctors that they interviewed left the public sector to go and work for NGOs or other agencies, and a considerable number also went to work full-time for private sector. This also occurred between senior doctors, with some of them with higher positions at the Ministry of Health level, or other higher position within the National Health Service. This is interesting study that was published recently last year, and this actually raises the issue that Beauty also raised, that universal coverage and also to achieve the ratio of doctors per inhabitants is compromised because of the difficulty that the government is having to employ. And this started in 2017, 2018, where the government actually changed the rules. Before, every doctor who completed the course had to work 2 years compulsory for the National Health Service, and they could continue if they wanted. Now, the doctors that complete their courses, they have to compete for vacancies that are open, and they are not open every year, or they are open by provinces and in very scarce numbers. And the amount of vacancies that are put forward or they are made available are very, very low compared to the number of doctors that are produced in the country. Now that we have some private and public, other private and public institution training doctors, we have an average of about 200 to 250 doctors trained a year. While before, when UEM was the only institution, the numbers varied between 40 to 70 or 80 doctors per year, depending on the intake. Let me take also this opportunity to say that UEM and other public universities, they actually are open to Mozambicans from anywhere. For example, for UEM, we have about 3,000 candidates competing every year for about 100 vacancies. And you can imagine the competition. And the exams we do, chemistry and biology, is just one criteria that is used to select. For Maputo, where we reserve 50% of the vacancies because the medical school is here in Maputo, of course, we take in account the marks that students get to get in the faculty. But for the provinces, where we have 2 to 3 vacancies per province, the marks are not the cutoff point. What we take the best among the ones that they compete in the provinces to get in the UEM. So this is very important. That's why we have a very diverse group of students. Some students that were very well prepared in secondary school, and we have students that were not that well prepared in secondary school, which also brings challenges for the medical school training.
I'm sorry to interject, but
yeah,
I see we only have 4 more minutes. Is this a there?
Thanks. Sorry to take too
no,
long.
it was perfect. I wish we had more time because you have a wealth of knowledge here, and I think it's super interesting to. You did a great job, kind of giving Mozambique's recent historical context, how colonialism and independence influenced our socialist government that we had after independence, how all that impacted medical education. You know, Mozambique and I are both the same age. We were both born in '75, and I often, despite all of our challenges, I marvel at where it is, you know, for being such a new country. But I thank you very much for your insights there. We probably have time for 1 or 2 questions, and I'd also be happy if people email me afterwards, relay any questions to our speakers and try to get back to you guys. But any comments or questions from our participants? I don't see anything in the chat. Dr. Miller, you have anything?
Yeah, I was just unmuting to thank you folks so much for sharing the history and the perspectives and some of the challenges that you're facing there. For the students in the selective, I just want you to know that this has been one of our strongest and long-standing partnerships, and we're really very grateful to the support from the dean's office at Eduardo Mondlane University, and also to the amazing leadership and mentorship that Chris Buck provides. And Chris is coming to LA soon, and we look forward to hosting him here and for all of our students to have the opportunity to connect with him. So, muito obrigado to our friends in Maputo. I hope that we see you there soon.
Thanks, Lee. I don't know anybody else. I didn't get a chance to introduce you, Sad.
No, that's okay. Chris, there's one quick question from the in the chat that maybe we can ask.
Sure. It says from Brenda, it says, how do you expect the private sector to change the landscape of healthcare in Mozambique? Who wants to tackle that question? Maybe you, Mohsen?
Very interesting question. Thank you very much. I think we are conscient that the public sector is not able to resolve the problem. As I mentioned, national service only covers around the best estimates around 60% of the population. So the private sector has a big role. And here, private sector, we need to speak about lucrative and non-lucrative private sector, because it happens in many other countries like Malawi, etc., where non-lucrative private sector has been playing a good role and complementing very well services for the population. So they have a great role, but the law that was issued in 1994, it was under pressure to quickly open because of multi-party elections, democracy, etc. And it's out of date now, and it needs to facilitate the implementation of private sector, because it was produced in a very suspicious context where the public sector was viewing private practice very suspiciously, and after the mentality, etc., that were accumulated during the single party needed to change. So, for example, now we are trying to put forward a discussion to review. Just this morning, I was in a meeting to review the private practice regulation. Even if a humanitarian organization wants to open a health facility, the bureaucracy and the barriers are so many that it becomes very difficult to open a health facility. So I hope I do that.
Yeah.
Thank you.
I didn't get a chance to introduce it at the beginning, but the gentleman who just speaking said, Dr. Saeed, is the new director of the Global Health Program at UCLA, and I hope all three of you guys have an opportunity to meet him. I think Sad's going to try to visit us next year, but Sad, thank you for your participation, and thank you so much to all three of you guys. I really appreciate your time. I think one thing I take away from this that you guys all highlighted is that you can't be just a clinician here, and the importance of the public health component of medical education here, given the health challenges we face, given the leadership roles that very young people are put into when they finish their training. And I hope we have a chance to continue this discussion in other fora in the future. But thank you so much to everybody, and have a good day. Okay.
Thank you very much.
Thank you.
Great pleasure to be here.
Thank you, Mohsen. Thank you, Beauty. Thank you.
Thank you.
Thanks, Chris. Really appreciate it.
Bye-bye.
Thank you.
Bye.